From Microbe TV, this is Infectious Disease Puscast, episode 24, recorded March 15th, 2023. I'm Daniel Griffin, and joining me today is Sara Dong.
Hi, everyone. I'm Sara Dong. Welcome to another Puscast. References, as always, are available in our show notes at microbe.tv, the home of our growing multimedia empire. Daniel, you're somewhere different today.
So I am in Arizona, a little south of Sedona. So that's such the surroundings. So hopefully we will not have technical difficulties. But
Oh, well, I'm sure it will be fine. Puscast is a review of the ID literature for the last 2 weeks that we found interesting or entertaining. So on to the literature, shall we? And I am kicking us off on the viral section. Remember to listen to TWIV clinical updates for timely viral related information. I, in this first paper, pulled something from OFID, an article entitled Re-Emergence of Paraechovirus, 2017 to 2022 National Trends of Detection in CSF. So this is a report that was in response to a U.S. CDC health advisory warning about increased paraechovirus circulation in the U.S. They took a look at some cases from the Children's Hospital at Vanderbilt and did a retrospective analysis of national epidemiologic trends of paraechovirus detected in the BioFire meningitis encephalitis panel CSF samples. So, of almost 76,000 ME panel results, the overall paraechovirus detection rate was about 1%, so it's a little under 800 cases, with major peaks in May to November of 2018, and then another one in April of 2022. And so the authors talk a little bit about how the COVID pandemic likely impacted viral dynamics, as the paraechovirus peak, along with some other viruses, was significantly reduced in 2020. And I wrote to myself, you can take a peek at the peaks of the national rates of paraechovirus and enterovirus and HSV2 in figure 1. That works a lot better if people are reading it. But most paraechovirus disease is subclinical, but for us in pediatrics, there are young children, particularly those under 3 months of age, where it can cause very severe disease with meningoencephalitis and really sort of a neonatal sepsis picture. And so I appreciated some insight into a little bit of the recent epidemiology, because there was the sense that we were having more cases than usual. So.
it's one of those things. If you look for it, if it's included in the panel of tests, you shall find. So maybe it's a plug for ID. It's getting more interesting because we're actually we're identifying things that we didn't realize were there because of these broad panel testing. So I'm very excited. All right. And we got some new recommendations on hepatitis B screening from the CDC with the MMWR screening and testing for hepatitis B virus infection, CDC recommendations, United States 2023. New recommendations include hepatitis B screening using 3 laboratory tests at least once during a lifetime for adults aged 18 or older. The 3 main serological markers used to determine hepatitis B virus infection status are, ready for this? Hepatitis B surface antigen, antibody to hepatitis B surface antigen, so anti-hepatitis B, and antibody to hepatitis B core antigen, anti-H capital B little c for core. And they include in this MMWR a guide to interpretation. The way I always remember is that hepatitis B core antigen, that's not in the vaccine. So if you got antibodies to that, it probably wasn't just the vaccine, but they estimated that compared with current practice, universal screening would be expected to avert an additional 7.4 cases of compensated cirrhosis, 3.3 cases of decompensated cirrhosis, 5.5 cases of hepatocellular carcinoma, 1.9 liver transplants. If I get my liver transplant, I want a full one, not that 0.9, and 10.3 HBV-related deaths per 100,000 persons screened. So does this make sense? Well, yes, universal hepatitis B, screening of adults aged 18 to 69 would save $262,857 per quality adjusted life year and result in a gain of 135 quality adjusted life years per 100,000 adults screened. I have to say that patients are often concerned about being discriminated against, about stigma, so they don't always tell their providers everything that would be relevant. These recommendations remove that. We just check everyone.
Yeah. Always a little bit easier when it's sort of a universal recommendation. Well, I'll take us over into our bacterial section. Be sure to listen to This Week in Microbiology. My second article is also from OFID, entitled Changing Epidemiology of Carbapenemases Among Carbapenem-Resistant Enterobacterales, or CRE, from United States Hospitals and the Activity of Astronium avibactam Against Contemporary Enterobacterales, 2019 to 2021. So part of this was taking a look at the epi of resistance mechanisms in CRE in the US. They found that the frequency of metallo-beta-lactamase and oxyacetylase type producers increased markedly, showing a significant change in U.S. medical centers. So there's overall decline in the KPC producers and an increase in metallo-beta-lactamase MBL. And this shift further limits what we have available for treatment because, as some people may know, our beta-lactam, beta-lactamase combos, the newer novel drugs that are currently approved, are not active against the metallo-beta-lactamases. Sofitenicol has some activity, although that really isn't the focus of this paper. And so one strategy to overcome this resistance pattern, the metallo-beta-lactamase, is to combine a MBL stable beta-lactam with a serine carbapenemase inhibitor. And part of this is because MBL producing Enterobacterales isolates generally co-produce ESBL, AMP-C, and or serine carbapenemases. And so sort of in the second portion of this paper, the other focus is the Astronium avibactam demonstrated potent and consistent activity against Enterobacterales across infection types and time. And so this was looked at against almost 28,000 isolates from 74 U.S. medical centers in that window. They did use broth microdilution testing and the Astronium avibactam breakpoint of less than or equal to 8. Yeah. I always have to, these types of the gram-negative resistance, it takes me a couple times to read through and make sure that I am understanding it all. So I picked this one to make sure I sat down with it and read through it.
Yeah, and I have to say, this stuff keeps evolving and is certainly a challenge keeping it all straight. The different types of resistance medicines, these newer medicines that we're bringing to the patient. Yeah, definitely a challenge. So appreciate you tackling that one. Well, I will take something a little bit easier, perhaps. So how long to treat that ventilator-associated pneumonia with whatever you choose? The article comparison of a short versus long course antibiotic therapy for ventilator-associated pneumonia. A systematic review and meta-analysis of randomized clinical trials was published in eClinical Medicine. So this is a meta-analysis that identifies 5 relevant studies involving 1,069 patients. So 530 patients in the short course group, 539 patients in the long course group. Well, what are those? Short course was 7 to 8 days, so just about 1 Constantine unit, and long course was 10 or 15 days. So the meta-analysis did not reveal any significant difference between short and long course antibiotic therapy for recurrence and relapses of ventilator-associated pneumonia. Now they say that odds ratio of 1.48, 95% confidence interval of 0.96 to 2.28 with a p-value of 0.08. and an odds ratio of 1.45, respectively. They then break it down a little bit differently. No difference was found for 28-day mortality, mechanical ventilation duration, number of extrapulmonary infections, and length of ICU stay. However, and I always love this, short course therapy significantly increased the number of antibiotic-free days. Of
It's your
course.
favorite, Daniel.
I'm like, yeah, actually, if we gave antibiotics for fewer days and we looked at the data, it looks like we were given antibiotics for fewer days. Like, I'm not sure. Like, by the way, reviewers out there, please put a line through that. Now, one of the things I will say, this all sounds fine, but I will encourage people to let us look at the forest plots. That's one of the things about meta-analyses is they may give you kind of a sum. We piled these cow pies very, very high and suddenly became gold. And here's our conclusion. I really like when they give us a figure with the forest plots and we can get a sense of what are the different studies suggesting. So I will suggest for all types of ventilator associated pneumonia, one, look at the forest plots, try to get a sense of which direction the data is headed.
I have an article entitled "The Time for Action is Now: The Impact of Timing of Infectious Disease Consultation for Staphylococcus aureus Bacteremia," which was published in CID. This retrospective cohort study compared differences in clinical outcomes in patients with Staph aureus bacteremia who received early versus late ID consultation. So their cutoff time here was 3.5 days. And so in these 670 patients, early consultation resulted in significantly greater adherence to quality care indicators. So 65% in the earlier group versus 40%, and then decreased length of stay, 13.8 days versus 16.9 days. So, if you're wondering what those quality care indicators were, they were identifying the source of bacteremia in 4 or less days, follow up blood cultures in 4 or less days, echocardiogram within 4 days, use of IV therapy, and the appropriate treatment duration. And then for other secondary endpoints, other than the length of stay that I mentioned, they did look at all cause in hospital mortality, Staph aureus bacteremia recurrence in 1 year, and a few other factors in 30, 60, and 90-day readmission rates. So just a little more, we like to pull out these papers thinking about the utility of ID consultation in particular earlier on in the course of illness.
Yeah, I love those consults. Patient is leaving today. Can you make oral antibiotic recommendations? I'm like, no. Please call us. Please call us much earlier than that. All right, let us move on to the article: intravenous doxycycline, azithromycin, or both for severe scrub typhus, recently published in the New England Journal of Medicine. So, for background, scrub typhus is a life-threatening zoonotic bacterial infection caused by Orientia Tsutsugamushi. Did you want to say that? Just because it just rolls off the tongue. And transmitted by trombiculid mite larvae. Just a little background. This is a public health challenge that exists beyond the so-called Tsutsugamushi Triangle, the region where this infection has traditionally been endemic in Asia and Northern Australia. I have seen several cases when I was in myself the Tsutsugamushi Triangle, and still remember one little girl with the classic eschar on her chin that served as the highly distinctive diagnostic clue. When this infection is untreated, the median case fatality is approximately 6%, but can reach 70% in severe disease. Severe disease, including multi-organ dysfunction and shock, develops in approximately 1/3 of hospitalized patients and can lead to death in approximately 1/4 of cases despite therapy. Now, I remember this girl because when I was examining her, she did not want to lift her chin and was left struggling because making children cry is something I hate to do. But yes, up went the chin, the characteristic eschar was revealed, and the crying started. The little girl cried, not me, by the way. I was inside where you can't see, but in this multi-center, double-blind, randomized controlled trial, the efficacy of intravenous doxycycline, azithromycin, or a combination of both in treating severe scrub typhus was evaluated. Patients who were 15 years of age or older with severe scrub typhus with at least one organ involvement were enrolled. The patients were assigned to receive a 7-day course of intravenous doxy, azithro, or both. They referred to that as combination therapy. The primary outcome was a composite of death from any cause at day 28, persistent complications day 7, or persistent fever at day 5. Among 794 patients, median aged 48, who were included in the modified intention to treat analysis, the use of combination therapy resulted in a lower incidence of the composite primary outcome than the use of doxy alone, or I'm just going to say, or azithro alone. We have 33 versus 47, 33 versus 48, so that 33 is better, for a risk difference really about 15%. No significant difference was seen between the azithro and doxy groups. Really summing it up, it looks like combination therapy was superior.
Cool. I have an article from MMWR, Chronobacter sakazaki infections in 2 infants linked to powdered infant formula and breast pump equipment, US 2021 and 2022. So Chronobacter is a gram-negative that can cause severe and often fatal meningitis or sepsis in young infants. I feel like this is a theme on a couple of the papers I picked today. But this is a report from 2 infants with meningitis that were reported in September 2021 and then February 2022. And whole genome sequencing linked one of the cases to contaminated opened powdered formula from the patient's home and the other to contaminated breast pump equipment. So the first case was a full-term infant that had Chronobacter grow from CSF cultures. He recovered without any issues or neurologic sequelae after a 21-day treatment course. The second case, though, was a preterm 30-week gestation infant who developed apnea, bradycardia episodes, and seizures. Chronobacter was found in blood and CSF cultures, but unfortunately, this baby died about 2 weeks after illness onset. So these cases actually were not related, but the point here being that this organism is ubiquitous in the environment. And I did learn, I guess not surprisingly, that this is not a specific nationally notifiable or reportable infection. So having a sense of exactly how many cases there are is a bit difficult. Previous investigations have noted Chronobacter's ability to survive in dry environments like powdered formula, but it also has been recovered from other environmental sources in the home. So kitchen sinks and pacifiers, and perhaps the feeding utensils that you go in and scoop out the formula with. So I feel like there was a lot of good messaging, particularly I think for those of us working in children's hospitals, where we're here to be on the lookout when there are cases reported of the Chronobacter contamination. But nice to have a little bit more information on exactly what happened, and something for people to be on the lookout for.
All right. The article, piperacillin tazobactam versus cefepime or carbapenems for cefoxitin non-susceptible Enterobacter cloacae, Klebsiella aerogenes, Citrobacter friendi, Serratia marcensis, and Morganella morgani bacteremia in immunocompromised patients. And that's, of course, the word that I have problems with. Was recently published in the Journal of Antimicrobial Chemotherapy. Here are the results of a retrospective cohort study in immunocompromised patients that investigated the effect of definitive treatment with either pip/tazo versus cefepime or carbapenems for bacteremia caused by cefoxitin non-susceptible Enterobacterales. There were more microbiological failures in the pip/tazo arm compared with the cefepime carbapenem arm. 11.4% versus 0. It's pretty impressive. Now, several members of the Enterobacterales order, such as Enterobacter cloacae, Klebsiella aerogenes, Citrobacter frandi, Serratia marcescens, and Morganelli morgani, can produce AMC beta lactamases that cause antibiotic resistance. Guidance from the IDSA suggests caution if prescribing Piptazo for serious infections caused by organisms at high risk of significant AMC production, and that the preferred antibiotic should be cefepime or a carbapenem. A number of limitations to this study, such as the retrospective nature, and note that this study looked at immunocompromised folks, but I do think this adds to the literature. And I have to say, with our antimicrobial stewardship, I feel like they're picking up on this quite a bit and alerting the clinicians.
Yeah. I have an article from CID. It's actually sort of two: positive impact of FDG PET CT on mortality in patients with Staph aureus bacteremia, explained by immortal time bias. And I would suggest that you can and should pair this with another article, PET scan in Staph aureus bacteremia, peeking under the covers. So, this is a prospective multi-center cohort study that found that PET scan was not associated with 90-day all-cause or infection-related mortality in patients with Staph aureus bacteremia after adjustment for immortal time bias. And so this is really in response to a couple studies that have been indicated that management with PET imaging was associated with decreased mortality. But given the large adjusted odds ratio, this raised questions about the validity of those results. As I pulled a couple quotes here. As a diagnostic test alone is unlikely to greatly reduce mortality unless its findings result in a life-saving intervention that would not have been performed otherwise. And so immortal time bias is the error in estimating the association and the outcome that results from misclassification or exclusion of time intervals. So depending on how the exposed and unexposed groups are defined, periods can be misclassified as time spent as exposed to an intervention when in fact the individual has not yet been exposed. So this bias can lead to overestimation of an outcome event rate in an unexposed group. It can underestimate the event rate in an exposed group, or have a mixture of both. Another way to explain this that I'll take from that editorial commentary, the peeking under the cover one, is that when receipt of a test or an intervention inherently guarantees that the patient was free of the outcome, aka they are alive for the time needed to get the test or intervention, whereas those with the outcome, those who are dead, could never receive it. And so back to this original paper, of the 476 patients, 37% underwent a PET. The 90-day all-cause mortality was 31%, and infection-related mortality was 17%. So the confounder-adjusted hazard ratio for all-cause mortality was 0.5, with a 95% confidence interval of 0.34 to 0.74. But with adjustment for immortal time bias, it changed this hazard ratio to 1, with a confidence interval of 0.68 to 1.48. So adjustment for immortal time bias also demonstrated no effect on infection-related mortality with the PET scan and on all-cause mortality in patients with high-risk Staph aureus bacteremia. And so this was I think I had seen snippets of this, of people discussing this on various papers on Twitter and so on. So I took this as an opportunity to read and think about immortal time bias. But for those who are interested, I think the sort of pairing the two together is very helpful to think about this topic. And I think it makes sense, just getting a PET scan alone, reducing your mortality in the double digits does, I think, intuitively is hard to make sense of.
If it seems too good to be true.
just a magical PET scan.
which no one can actually get in the inpatient setting anyway.
Yeah.
So I'm not even sure how this was ever supposed to, improve things. But moving into fungal, and I'll encourage everyone to watch The Last of Us. If I
Oh,
could
it's so
plug for
good.
that show. That's
So
actually, I
good.
was watching that. I'm on vacation, it's spring break with my college daughters. So I did interrupt my watching of The Last of Us. I am binging. Now, my form of binging is I'm up to episode 2. So,
Oh,
all right.
no, only 2. Oh, you have so much left. Oh,
All right. I got
well,
a lot
we can
left.
connect
This is
after.
great. Okay. Well, we're expecting rain. So, the article Association of Antibody Immunity with Cryptococcal Antigenemia and Mortality in a South African Cohort with Advanced Immunodeficiency Virus Disease was published in CID. We've discussed the ongoing issue with cryptococcal infection on prior episodes, including on our last episode. And here are the results of an investigation looking at the association between antibody immunity, cryptococcal antigenemia, and mortality in a South African cohort with advanced HIV with and without asymptomatic cryptococcal antigenemia. So the investigators reported an inverse association with cryptococcal capsular, I'm going to say GXM IgG. That's your, I'm going to try to pronounce this, glucuronoxylmanin IgG with mortality in the cryptococcal antigen positive individuals, suggesting that the titer may have prognostic value in these individuals. So really looked like, this higher probability. If you actually, they broke it down. If you look at those with really high IgG levels, really great survival. If you looked at the group with the low, really seeing survival down at about 50% when you get out past about 150 days. So nice to have another way of figuring out where things are headed.
In JPIDS, a practical guide to antifungal susceptibility testing was published. And, the title really says it all. This is an overview of susceptibility testing, development of clinical breakpoints, and provides an approach to thinking about results when breakpoints are not defined. I know I've referenced other sort of review articles covering antifungal susceptibility testing. This one specifically for thinking about it in the pediatric context. Table 1 has a really nice comparison of the UCAST and CLSI breakpoints, uh, mostly highlighting that the ECV or ECOFs have only been defined for some organism drug pairings just due to the rarity of some of the fungal infections that we see. I think pulling out one special note for pediatric patients is that extrapolating adult doses to younger patients often results in under overdosing for children with invasive fungal disease, because as we know, PK is influenced by age and body composition and how your kidneys and liver sort of handle clearing the drug. And so a really great example that I feel like I've seen a lot on service. I've been on the immunocompromised service, but also as noted in the article is how voriconazole is cleared very rapidly in children and leads to a lot of variability in the drug levels. Not that they're super easy to track in adults, but even more variability in children. So just another nice guide that people can check out to get an overview for what is often a very challenging topic.
All right. Now, this is one of those crossovers that could be on our TWIV clinical update, or even here early on in the viral section, the article Risk of Coronavirus Disease 2019 Associated Pulmonary Aspergillosis, based on corticosteroid duration in intensive care patients, published in OFID. So, right up front is the comment that these are the results of a retrospective cohort study of adult patients with severe COVID-19 pneumonia requiring mechanical ventilation who received at least 3 days of corticosteroid treatment. Not an RCT, so all those caveats, the two groups are not exactly the same. A total of 278 patients were included, 169 for the less than or equal to 10 days of steroids, and equals 109 for the greater than 10 days. And we are looking at CAPA, C-A-P-A, Coronavirus Disease 2019 Associated Pulmonary Aspergillosis. That's a good four-letter acronym I will have to memorize. They report that kappa developed in 7.2% of the patients. And let's break it down for those greater than 10 days, 11.9% versus 4.1%. So that's going to give us an odds ratio of 3.17. So more than 3 times as likely. Also, will mention secondary outcomes included inpatient mortality, 77% versus 43, mechanical ventilation days, secondary infections, interesting, 44.9% versus 28.4, worse in that greater than 10 days cohort. Growing amount of evidence that while steroids make a difference, we really need to be careful about that duration. In your floor patients, maybe it's 6 or less days. In your ICU, let's really keep an eye on that 10 days. But remember, these are not the same. The folks that we're keeping on for more than 10 days, usually something is going on there. So this may be more of an indicator, but keep an eye. We also have the article. I should have given this to you, Sara, because it's about Candida auris. This is the one pathogen that I don't know. The article, The Emergence and Persistence of Candida auris in Western New York, nonetheless, Western New York with no epidemiological links, a failure of stewardship, ? This was published in Open Forum Infectious Disease. So for some background, United States, the first case of Candida auris has been traced to New York. Here, the authors described a case of C. auris in a patient hospitalized in a small community hospital in Genesee County, New York. I'm Googling to see how far away I am, with no known epidemiological links to other cases. They do report that during his stay, he occupied 4 different rooms in the ICU. Why do they keep moving this guy? They reported that the rooms that the index patient occupied, up to 75% of services tested after terminal cleaning had detectable nucleic acid, and 25% had culturable C. auris. You're beginning to see my fear. They did have 2 ID docs review the case, and they reported the patient had 60 days of excess or inappropriate antibiotics prior to the clearance of the C. auris. Where were those ID docs? All right. Well, parasitic, we're going to just tell you this week to be sure to listen to This Week in Parasitism for those articles, those great clinical vignettes, those mystery cases, and we will wrap it up right here.
Yeah, that brings us to the end of this podcast. As always, the references for this show are available at microbe.tv, the home of our multimedia empire.
You can find the Infectious Disease Puscast at Apple Podcasts, microbe.tv/Puscast. We love to get your questions, comments, and paper suggestions. Send them to puscast@microbe.tv. If you like what we do, consider supporting the science shows of Microbe TV at microbe.tv/contribute, or Parasites Without Borders at parasiteswithoutborders.com, and click on the donate button.
I'm Sara Dong. You can find me on Twitter at @swindong, at Febrile Podcast, or at febrilepodcast.com.
I'm Daniel Griffin, and you can find me at parasiteswithoutborders.com, on Twitter at Daniel Griffin MD, as well as on the other podcasts, This Week in Parasitism and This Week in Virology Clinical Updates. And as always, thank you for this most interesting consultation and allowing us to participate in the care of this most difficult and challenging case. We shall continue to follow along with you. Thank you, and dictation, and goodbye.
Thanks for listening. We'll be back in 2 weeks. Another podcast is infectious.